So good afternoon. Before we get started with the actual business of the meeting, you all need to be sworn in as members of this task force. So even if you're like Senator Friedman, like totally sworn in and all kinds of things, you still have to swear in for this one. So I am joined by my colleague Millie Bhatia, who will be serving as our witness.
To wait for Lauren to come back. Oh. The other Lauren, sorry. Sorry. Great flag. The other one.
And Millie and I are both what are known as commissioners to qualified public officers, which is to say that we are authorized to administer oaths of office for the Commonwealth. So I will be leading you through the oath line by line. And you'll have to insert your own name whenever I say state your name. Don't repeat, state your name. So if you could please raise your right hand and repeat after me. I state your name. Do solemnly swear. Will bear true faith and allegiance. The Commonwealth of Massachusetts. And will support the Constitution thereof. So help me God. I state your name. Do solemnly swear and affirm. That I will faithfully and impartially. Discharge and perform. All the duties incumbent on me. As a member of the Primary Care Task Force. According to the best of my abilities and understanding. Agreeably to the rules and regulations of the Constitution. And the laws of this Commonwealth. So help me God. I state your name. Do solemnly swear. That I will support the Constitution of the United States. Congratulations and gratitude for accepting to serve as members of the Primary Care Task Force. For those of you who know me, know that I tend to start meetings with poems. So today will not be an exception, but I chose a really short one because David said I only had 5 seconds. So the title of the poem is called To Be Alive by Gregory Orr. To be alive, not just the carcass, but the spark. That's crudely put. But if we're not supposed to dance, why all this music? So we will, before we actually launch into the meeting, we have some other business to take care of, which is open meeting law compliance overview by Lauren Cleary. Most of us are familiar with open meeting law, but there are always variations and interpretations. So we're doing a review to have everybody start from the same place. Lauren here? Yes, other Lauren. Go ahead.
Good morning, all. I'm going to make this quite brief because the overall rules of open meeting law are quite basic, and the issues and complications come in applying those rules to very specific fact situations. So I'm always available to answer questions as those situations come up. So just to give you a brief overview, the whole point of the open meeting law is public access to your decision making. And the Division of Open Government of the Attorney General's Office enforces the open meeting law. The guidance that you received along with the regulations and the law, please review that. There is also a form to sign and to return within 2 weeks if you can, and that becomes part of the file here, part of the public record here. The basic principle of open meeting law for this body, for this task force, is that any deliberations, any conversations, any meaningful or opinion-based communications around the areas that are within your sphere of jurisdiction based on the statute must take place in a publicly noticed public hearing such as this one. That sounds very simple. And it basically is, except when we get into our technology and we're emailing and forwarding emails and texting and forwarding text messages. Because if you get to a quorum of members, which for you all is 13, it's the simple majority of the number of seats, whether they're actually filled or not filled, but a simple majority. So if your communications about the areas that are within your jurisdiction by statute reach 13 people, that would be a violation of the open meeting law. So just be careful about forwarding emails and text messages. It is completely fine to forward agendas, documents, other types of material that you want to share with everyone, as long as people aren't offering opinions about those materials. Save the opinions discussion for the open meeting. I know there will be some consideration at some point of potential working groups. Some of those would fall under the open meeting law into subcommittees, which themselves must follow the open meeting law. And so they would have to also notice their meetings, have the meetings in a publicly available forum, if they reached a quorum of whatever that smaller number of people on the subcommittee would be. There are also working groups that can be created that are much more informal, that would just involve data gathering and such things. We can deal with that when the issue comes up, when you figure out how you want to manage the workload that's involved. My understanding is that you will probably not need to go into executive session very often. The one reason that you might would be trade secrets. If you had to go into executive session, meetings are still, I'm sorry, minutes are still taken during the executive session. And all votes during executive session are by roll call. Even though that is a private closed executive session, in a public records request, we would have to look to see whether the factors that caused you to go into a closed meeting still existed. With trade secrets, it probably would, so those would probably remain subject to exemption from the public records. For those of you who aren't already state employees, just be aware that your emails, your texts are probably all public at this point in relation to this task force. Just, I know we can tend to be very loose on email and text and friendly and emoji, and you probably all don't do that. But just be aware that it is public, and so you'd want it to be something that you're happy to release publicly. Anything that you receive in the course of your work on the task force is also potentially a public record. Memos, opinions that you might write and share. So just keep that in mind as well, that you are working within a body that is open to the public viewing and accessing the transparently what's going on here. And I think that's really the basic outline. Beyond that, issues will come up. Sometimes it's hard to function in between meetings to figure out what work can we get done in between open meetings to keep things moving along. And I'm happy to be available to answer any kinds of questions about open meeting law. Thank you.
Thank you, Lauren. David and I will be providing some context over the next probably half hour. But I just wanted to have some opening remarks. Number one, UHHS is very excited to be working with the Health Policy Commission on this primary care task force. And I wanted to state some obvious things. Number one, complex systems are by definition complex and very difficult to improve and to change. In healthcare, certainly one of those very complex systems, which involves this complicated imbrication of stakeholders, of whom you present some, and also including government players. By design, the American government lends itself By design, American government lends itself to incremental and considerate change. David will be setting the background of the crisis that we're trying to address of primary care, and I will later reiterate the legislative mandate. The main purpose of these words is to emphasize that this task force represents an opportunity to resolve an existential challenge to our society and our system. I will not be so Pollyannish as to ask you to put aside the interests of the institutions that you've been nominated from, but I would like to explicitly state that without significant change, we will not be able to propose realistic options for the resolution of our current crisis. And to remind that everyone as humans, when we call for change, we generally mean that other people have to change. But in order for the primary care crisis to eventually serve people in the way that we would all like, each of us and all the institutions that we represent will have to change something in order for the status quo to actually make way. And despite my generally three-quarters empty perspective, glass empty perspective on the world, I'm excited by the work ahead and look forward to the work of this primary care task force. David?
Thank you, Kiame. Good morning, everyone. It's great to be able to host this inaugural meeting of the Primary Care Task Force here at the Health Policy Commission. I am David Seltz. I'm the Executive Director at the Health Policy Commission. We're an independent state agency focused on improving the affordability, accessibility of healthcare, and improving health outcomes for all the residents of the Commonwealth. I'm really honored and humbled to be the co-chair with you, Dr. Mahania. You bring so much personal and professional experience to this work, as does everyone around this room. As I look around this room, I see many familiar faces that we have worked together for many years and some new faces, and I'm excited to get to know you and to tackle this work together. As Kiame said, we're really grateful for your time, commitment, and constructive engagement in the essential work of this task force to improve primary care in Massachusetts. On behalf of both of us, we're excited to learn from you and to engage with you on problem solving together on one of the most consequential and impactful challenges in healthcare. We know that there are many threats facing our healthcare system today and our higher education system. And at the same time, our employers, especially our small businesses, families, retirees, state and local government, they're all struggling with the high cost of healthcare. And they are also facing incredible uncertainty and inflationary pressures of their own. We know that you are all stretched in many different directions these days, but we have this opportunity. We know that reforms are needed on the way that our system pays for and delivers primary care for all of our patients, and that reforms are needed to support and empower our dedicated and compassionate workforce that care for our families and for our neighbors. Our healthcare system is unbalanced and needs realignment. We live in a state that has always been a national leader on public health, on health policy, and has its unwavering commitment to improving care, improving access, and improving health for all residents. And these values, I think, are deeply embedded in our Commonwealth. We were the state with the first public health department. We're the state with the first community health center. We're the first state to have universal coverage and the first state to tackle setting our state on a sustainable path for healthcare costs. We did all of these things as a state, and we can do that again. As I'll talk about later, there are other states that are innovating and experimenting on health policy that go beyond where Massachusetts is today. But we can, and I believe we should, seize this opportunity to be a model state for meaningfully tackling the challenge of changing the trajectory of primary care delivery to one that actually works for patients, puts their health needs first, supports our essential workforce, and ultimately improves health outcomes. If we succeed in this work, which we must, we'll leave behind a healthier, stronger, and more affordable healthcare system that treats patients according to their needs in the right place at the right time. With that in mind, as we pursue this work, I hope that we keep our ambitions bold, our sense of urgency strong, and that our collective commitment to finding consensus and compromise will be our North Star. Even if we may not always agree, I hope that we can keep our focus on what's best for the residents of the state, consistent with the oath that we all just took. I really want to acknowledge at the outside of this task force, the leadership of the legislature that made this possible. Representative Vaughn, Senator Friedman, Senate President Spilka, and Speaker Mariano. Without their dogged commitment to getting these important bills done on the waning days of the session, we would not be here today. And I'm really grateful for your leadership. I also want to acknowledge that our governor has thrown down the gauntlet on this issue. She said at her State of the Commonwealth repeatedly that we need to make sure that primary care is the foundation of our healthcare system and that we need to come together on solutions. Mass Health has stepped up and is pledging to increase the investment on primary care, building off of the success of past payment models. And we know that there are other important innovations in the market today. We're committed to making this task force a success because candidly, we don't have another option. The residents of the state are loudly and emphatically saying that the cost of healthcare is too high, the system is too complex and opaque, and they can't get the care that they need due to the cost of care. And when they can't get into their regular provider, they too often choose to go to the emergency room instead. We know this contributes to ED boarding. We know this contributes to capacity challenges within our hospitals, which are well documented. As a past member of many different types of task forces and commissions, it's my experience that we get out of this what we collectively put into this. And that's why from EUHHS and HPC, we are dedicating our time, our staff, and our resources to this work. This cannot be another commission that just kicks the can down the road and puts forward recommendations that no one acts on. I hope that you will join us in the spirit of urgency and action. So thank you again. As we kick off this meeting, you have an open door to us, recognizing open meeting law requirements. And I am optimistic, in spite of everything that is going on around us, that we can collectively agree to some real solutions to stabilize and strengthen primary care, both in the short term and in the long term. If not us, then who? I really want to be able to have an opportunity at this first meeting for all of you to introduce yourselves and share how you came to be in these positions. And later in this time together, we'll have some discussion time to talk about what priorities you all have for the work of this commission. But first, before we dive into introductions all the way around, I want to ask Senator Friedman and Representative Vaughn if they'd want to provide a few opening remarks as key authors of this task force. So, Senator Friedman.
Well, thank you, David. If I had realized I was going to be put on the commission, I might have written it a little differently. But seriously, though, I am so happy to be here, and I am so relieved to see the people who are around this table. We talk about a crisis. We're beyond a crisis. This is just, we are really in what I would call the fourth layer of Dante's Inferno, right? I mean, to even talk about primary care being in crisis does not do it justice. And this really task force came out of listening to a lot of people in the primary care space that were saying, get us around the table and let's have a real discussion. And that was a message to me, certainly, that was loud and clear. And so while I frankly hate commissions and task force, I have been on some that have been truly transformative and have really done amazing work. And I will commit to you that this commission, I will do everything to make sure that this commission meets those standards and the standard that David and Kiami have laid out, because we can't go any further unless we solve this problem. And it really means that we're all going to have to take steps that are going to feel a little shaky, and we're going to have to make decisions that are not going to be perfect sometimes, because you have to do it to figure out what's right and what's wrong. And we're going to have to be very courageous about putting aside what have always been these very entrenched ideas and issues and moving beyond that. And what I really hope is that the word we hear, or the words we hear the least, is no, we can't do that. Because we spend a lot of time talking about what we can't do, and it gets in our way. And this system is so ridiculously complex because it's meant to be complex, because it's meant to keep everyone entrenched where they are. And if we continue to follow that line, we will not have a healthcare system. We just won't. I feel that strongly about it. We're not talking about, oh, we can make it better. We won't have it. And so I just urge everybody to come with that notion of urgency. And I will certainly commit from the Senate that we will do whatever we can to solve this problem in a way that actually the people who are receiving the care and the people directly giving the care will feel the difference. So thank you. I see many, many friends around this table, many new people, and I just can't thank you enough for being willing. I know some of you were cajoled into this, but I will take you as I can get you, and really, really appreciate your service.
Representative Vaughn.
Thank you, David, and thank you, Kiami, for chairing this important task force. And also, I'd just like to credit my co-chair, Senator Cindy Friedman, for her leadership on this, which she has been for several sessions, really raising this issue. And I know sometimes we all try to get to a place of an agreement. And as we know, this is a very complex issue of making sure that we can meet the challenges that we have in primary care. We know they're very multifaceted, and it takes a lot of people around, and I really am excited to be part of this group. And I really think this is a group that really can come up with some real solutions together, and really come together and try to reform in a time where we know this country's in crisis in so many levels, especially in healthcare. And maybe it is an opportunity to do a real reset on the challenges that we have. And we know that primary care is how we keep health costs down. We know that we have workforce challenges. We know we need to invest further into primary care and insurance and other areas and support. And I think that this task force really gives us a chance, which are very broad and experienced and knowledgeable group of healthcare people here in Massachusetts. It gives us a really good chance to come up with something really productive. And I really am looking forward to this, and I appreciate being a part of it, and I appreciate everyone who's here this morning. I look forward to this very much. So thank you very much.
Thank you both. Thank you both for your leadership. At this time, I do think we would love to have everyone just be able to introduce themselves and the organizations that they may be representing. As you all know, in this law, this is a 25-member task force, and just about every single one of the designated spots was laid out in statute. And so we reached out to all of these organizations to nominate you as members, but want to begin this meeting with those introductions. I will say we do want to keep time at the end for broader discussion of goals and priorities for this task force. So 25 people, please be generally brief. But if you look in your binders under the presentation tab, you'll see the slides that will be guiding our conversation and discussion today. And if you flip to slide 3, you can see here the full task force membership laid out. And so I'll just we'll be going through this kind of as laid out on this slide for introduction, so you can see where you are. First, I do want to recognize some of our other important state partners that are a part of this effort. So I want to begin with Commissioner Caljo. And one last thing, sorry. All the microphones, green light is on. You can just leave them on, pass them to your friend, push them away, but you can just leave them on.
Great. Thank you, Director Seltz and Secretary Mahania, co-chairs of this commission task force, and also tribute to Chair Friedman and Chair Lawn for their leadership on the topic. I'll be really brief, given the fact that there's so many people. I'm a fairly new appointee as the Commissioner of Insurance by Governor Healy. In my first meetings with the governor, she stressed the importance of primary care reform as very high up on her list of priorities. And I'm excited to do some time-sensitive work. I do think there's an urgency of action here. The status quo is not acceptable. And we have the benefit of critical timing because these recommendations can help provide a springboard as we enter into the legislative cycle and continue that work. In my mind, I think there's a multi-pronged set of answers that include private market leadership, continued legislative reforms, and then the use of existing regulatory authority to accomplish the goals that we have. And I think all three of those items have to be on our list as we consider the actions.
Thank you. Director Peters?
Good morning. I first also want to echo thanks to our chairs of the task force, Director Seltz and Undersecretary Mahania, Chair Friedman, Chair Lawn, again, for your leadership on this issue. This is a topic that I've had the opportunity to work with many of you around the table for close to 7-8 years at this point. And as the executive director of the Center for Health Information and Analysis, otherwise known as CHIA, we are looking forward to continuing that partnership and providing the fact base and the data to support both the efforts, inform where we may need to go. And I would also just use this opportunity to highlight the report that we released this morning, looking at primary care and behavioral health spending trends in 2023. And I think we will all see, the data only reinforces not only the need for this work, but also for the urgency. So I look forward very much to continuing the dialogue in this task force and being a resource for everyone around the table.
Thank you. And that report is included in your binders, as Lauren said, just released this morning. Dr. Schwartz?
Thank you, and thank you to everyone for being here today. I'm Ryan Schwartz. I oversee MassHealth's Office of Accountable Care and Payment and Behavioral Health, and in that role, we largely focus a lot on our managed care organizations as well as all of our primary care and behavioral health efforts. I'm also an internal medicine and pediatrics physician at one of the health centers in the Boston area. In the spirit of brevity, I will merely say that this meeting is long overdue, and I think I know most of the folks around this table, and we've been having this discussion for the better part of 2 decades. And so it is good to see this group together. And I think to echo the words of those before me, if we miss this opportunity to actually do something and write yet another report to go on the dusty shelves, we're missing a critical opportunity for every resident in Massachusetts. MassHealth has been on this journey with primary care as a key priority, both under the Baker administration as well as now under the Healy Driscoll administration. And we're very committed to primary care as one of our top priorities. We have really tried to think differently about primary care over the last 5 years in particular. However, while we can continue the work, and I think we have seen some signs of success, frankly, anything that we do on our own is inadequate and insufficient to actually address the problems we have. And so I'm sorry. Thank you, Kiana. I was merely saying that anything that we do at MassHealth is going to miss the broader problem if we are the only ones working on that. And so I'm thrilled to be here and would hope that all of us can work together to find a collective opportunity to really change this situation. Thank you.
Thank you. And we'll just continue with introductions. Dr. Wayne, I'm actually just going to do an audible, and instead of going alphabetical, we'll just go straight down the row. And so, please take advantage of the microphones. We are live streaming this, and there are a lot of interested parties who aren't in this room and want to hear everyone. So, Dr. Altman.
Good morning. Chair of the Department of Family Medicine at Tufts Medical School. I'm a family physician and a co-owner of a private practice in Arlington, and I'm the founder of a grassroots organization called MAPCAP, Massachusetts Primary Care Alliance for Patients, which we started about 6 years ago with the intention of having the 25 of you come around a table on April 16th, 2025, and get this done. I've heard the words crisis and opportunity, and it really, I heard something recently in Mandarin. The word for crisis is 2 Chinese characters, and those 2 Chinese characters individually are danger, which we understand the danger, and the other word is opportunity. And we really have an opportunity to get something done here, and I know we will. We have 3 primary care bills before our legislature right now that have all the ingredients we need to get this solved. And I know that we will do something in this session. The question is, will it be good or will it be great? And this group has the opportunity to really do the work to make it great. I'm honored to be here.
Hi, Laura Pellegrini, President and CEO of the Massachusetts Association of Health Plans. Thank you for having me here today. And thanks to Chairwoman Friedman and Chairman Lawn for the passage of the important legislation that made this task force possible. We had a very enjoyable Christmas and New Year's, thanks to you, but very important work. And so thank you very much. And we've been working with Wayne now. I asked him if it was 4 years. It's actually been 5 years. He and his group on their proposal. And while we still do have some differences, I think philosophically we agree primary care is the backbone of the healthcare industry. We need to reinforce primary care. We need to attract young people who are looking to go into medicine, to join primary care and not to decide to be a dermatologist or a plastic surgeon. And so the work we're doing here is very important and much overdue. So thank you.
Good morning, everybody. My name is John Hurst. I'm president of the Retailers Association of Massachusetts. We are a statewide trade association of 4,000 primarily small retailers and restaurants, on average about 10 employees. And I welcome the opportunity to be here. I can tell you there's certainly a crisis in healthcare. There is a huge crisis in small businesses across the Commonwealth today. We're coming out with a study with UMass Donahue Institute this spring that's showing 51% of our small businesses across the Commonwealth are going to be closing their doors within the next 5 years. That's on top of what we've already seen in the wake of COVID, of countless dark storefronts. And the number one issue that they cite of a number of costs is, of course, the disproportionate hit on small business health insurance, which is hurting their bottom lines, hurting their ability to recruit and retain a good workforce. So this is important. The retail industry has always survived and thrived based upon value and efficiency. And my view is value and efficiency is what primary care should be all about. And if we can really instill that into the healthcare infrastructure in Massachusetts, it'll be a great win for our economy.
Hello, everyone. I'm Dr. Judith Mellon. I'm the governor, which is the president of the Massachusetts chapter of the American College of Physicians. At the national level, that's the largest specialty organization of physicians in the country, 161,000. At the state level, of course, we're much smaller, several thousand medical students, residents, and practicing internal medicine physicians, many of whom are practicing in primary care. The remainder are practicing in subspecialties and in hospital medicine. And all of us are delighted at the opportunity to improve the situation for primary care physicians. I am one of those primary care physicians. I practice at Beth Israel Lahey Health at the Lahey Hospital and Medical Center campus, and have spent significant portions of my career working with colleagues around the table here around healthcare financing and assuring optimal outcome for our patients. One of the things that I pay a lot of attention to is assuring that the word patients comes up in conversations like this, and I'm delighted to have heard it several times and wanted to emphasize that all of us from ACP are extremely committed to the goals of the commission. I also of the the task force. I also am the co-chair, the chair of the Committee on the Quality of Medical Practice at the Massachusetts Medical Society. Thank you.
Hi, everyone. My name is Laura Black. I am the current president of the Mass Coalition of Nurse Practitioners, which represents approximately 10,000, even more NPs in the state of Massachusetts, more coming. We are the largest growing workforce, well-positioned to support the primary care effort. On a personal level, I am a primary care provider at a nurse practitioner-owned independent practice that's based in North Brookfield. We service about 3,800 patients. About 35 to 40% of them have Mass Health or they're on direct. And we really have a very high value delivery system for our patients. We are struggling to keep our doors open because, again, as an independent practice, trying to work within this framework, it is very difficult for us to be able to maintain and be able to continue to care for our patients. And I'm very happy to be part of this and excited to see how we can support the effort.
Hi, I'm Brenda Pring. I am a pediatrician. I'm here representing the American Academy of Pediatrics Massachusetts chapter. We have about 1,700 pediatricians in Massachusetts. We advocate on behalf of children and pediatricians. And so we're here with that patient voice, but also for all children in the Commonwealth and their families. Clinically, I work at Atrius Health and at the Beth Israel Hospital. And just wanted to just comment that, and I also used to work in government long before I started a career in medicine. So this is a good opportunity to bring to be at the table. Thank you for that. And I just want to say over the past several years, we've seen, as everyone knows from a physician perspective, that there has been more decrease in the workforce in pediatrics specifically since the pandemic. There's more demands on physicians and the pediatricians are typically at the lowest income bracket of physicians. And so we're just seeing more attrition in our practice, which is very sad to see. And our mission is really to care for those families and keep going. So I'm excited about this. Thank you. Good morning, everyone. My name is Sarah Mills. I'm the Vice President of Government Affairs at the Associated Industries of Massachusetts, where I focus on our healthcare policy work. We represent 3,400 members across the state that are in over 150 sectors. A majority are small and medium-sized businesses, and similar to what John said, we are hearing about the cost of healthcare for our small and medium-sized businesses more than we're hearing about any other policy issues. So very grateful to have a seat at this table, and I'm looking forward to the dialogue. Thank you.
I'm Dr. Matthew Libby. I'm representing as an alternate delegate the Massachusetts Academy of Family Physicians, the Massachusetts chapter of the American Academy of Family Physicians. I'm a board member and treasurer there. Outside of that role, I've spent most of my career practicing in and in leadership positions in several community health centers in Massachusetts. I'm currently serving as the interim chief medical officer at a small healthcare for the homeless FQHC on Cape Cod. And I spent a couple of years in the primary care startup space in between some of those roles. As far as the Mass AFP's interest, we represent over 1,000 family physicians in the state, the vast majority practicing primary care and in a variety of settings. So community health settings, private practice settings, hospital-based academic settings. And the Mass AFP has supported a variety of different solutions. We're not really committed to one particular pathway to solve this problem, but we spend a lot of time hearing from our members and seeing the different ways in which the current state is not working. So we have supported legislation that would be fully public, sort of Medicare for all type plan. We've supported plans that are proposals that would be existing within the commercial space, and even recently proposals that would be much more free market than is the current state. So really across the spectrum, anything that's going to work and actually make it better we support in trying to fix the job of primary care, fix the pay of primary care, and increase the workforce.
Thank you. We'll switch over here.
Hi, my name's Eric Dixon. I'm an emergency physician, self-proclaimed healthcare socialist who believes Medicare for all is the solution. But I don't think I'm going to get that. So we're going to have to try to fix healthcare in another way, starting with primary care. I run UMass Memorial Health out in Worcester. And I'm here representing the Mass Health and Hospital Association. It's a pleasure to work with all of you.
I'm Barbara Spivak, and I'm here representing the Mass Medical Society, which most of you know represents 25,000 physicians across the state, primary care specialists, surgeons, internal medicine specialties, includes students and residents. Personally, I'm a primary care physician who's practiced in Watertown for well over 40 years. I won't give you the exact number because that'll age me out. I've been very active in the Mass Medical Society for years, being the chair of the Quality of Medical Practice Committee before Dr. Mellon. I also ran the Mount Auburn Cambridge IPA for 27 years, having just stepped back in December. And for those who don't know, we were very innovative in terms of our developing care management programs long before anybody created the term accountable care organization. We were the first to sign on to the Blue Cross AQC. We were one of the first Medicare pioneer ACOs. I believe and have actually built an organization based on innovation and payment reform. And I'm really honored to be representing the society, but be part of this. And I'm really hopeful that we can make some changes. Thank you.
Hi, I'm Mark Friedberg. I'm Senior Vice President of Performance Measurement and Improvement at Blue Cross Blue Shield of Massachusetts, where I've been for about 6.5 years. My group there focuses on improving the quality, equity, value, and experience of care that our members receive in and out of state, but primarily in state. I'm also a general internist. I practiced primary care at Brigham and Women's Hospital for a little over 20 years, part-time. And previous to my role at Blue Cross, I worked at the RAND Corporation for about 10 years, where pretty much all the time I was spending on thinking about how quality measures and different ways of paying primary care providers actually work in the real world, and have a lot of experience in that area. Also with Michael Baylett and colleagues developed the first ever primary care spending measures, which are the sort of root of many of the measures we'll be talking about here.
Patient access to high quality primary care in every corner of the Commonwealth is one of the keystones of the Mass League of Community Health Centers. I'm Dr. Renee Critchlow. I'm a family physician, and I'm honored to be representing the Mass League of Community Health Centers. Over 52 health centers around the state. We're doing a bit of the bona fides. I am also the immediate past president for the Society for Teachers for Family Medicine, National Society for over 3,000 family medicine faculty. I am also the immediate past chair of the Commission for Federal and State Policy for the American Academy of Family Physicians, representing over 130,000 family medicine physicians across the country. Payment reform, practice redesign, and empowering the pipeline. Everyone's talking about being effective. We're here to do something different. We're here to solve the problem. Kiame, we're here to solve the problem. I was raised with the lead follower, get out of the way mindset. I think this task force here to lead. We have to leave with something being done. And a lot of that is getting out of our own way. When I moved to Massachusetts recently, I've practiced both rural and urban primary care for my entire career. And I was asking the folks that were embedded in Massachusetts politics, I'm going on this task force, what should I look out for? They're like, a task force that size is just to protect turf. It's not to make things change. And I said, I don't believe you. I believe this task force is going to be different because we have to be different. Our patients need us, our communities need us, and we can do this. The answers are there.
Hello, everybody. My name is Barbara Rapson, and I'm the president and CEO of the Massachusetts Health Quality Partners, which is an organization for the past 30 years. Our mission has been to improve the quality and equity of patient experiences of care through data-driven insights and collaboration. And I first want to thank Senator Cindy Friedman for all the work she did getting us here. I think she's been a true leader, and we need it. MHQP is focused. The reason we, as an organization that's been measuring patient experience, got into focusing on primary care is that before COVID, we became aware of how fragile our primary care system was. And we've been measuring the performance of primary care for 20 years. And then when we realized how fragile it was, we said, wait a minute, we need to monitor the health of primary care, because the primary care is the front door to our healthcare system. And if the front door is closed or broken or backed up, that means the whole system will not work efficiently and effectively. And we're already seeing that. So I want to just say that we bring, MHQP has 3 different primary stakeholder groups, patients, clinicians, and health plans. And so I think we've had lots of practice with bringing voices together. And I think that that's key to this group, is to be able to integrate all the separate solutions we have into a single one. And I would just want to note that MHQP started working with CHIA. And in 2023, we produced the first in the nation dashboard on the health of primary care. And that really has been a really key place to monitor what's going on. And unfortunately, everything keeps going south. So I'm delighted that we're here today to talk about how to stop that destruction of our healthcare system. And just also note how important primary care is, not just for Massachusetts, but the whole nation. And the National Academy of Science, Engineering, and Medicine put out a report in 2023. They had put out a report in 1996. And then they had to put it out again because there was no accountability and nothing happened. And so we can't afford that. So I think we have a lot of colleagues to look to, as I think David mentioned, across the country. I work with a lot of them and look forward to working with you all to get the solutions we need. Thank you.
Hey, good morning. My name is Christina Severin. I'm the president and CEO of Community Care Cooperative, or C3. Thank you, Dr. Mahania, Director Seltz, Senator Friedman, Chair Lawn, and all colleagues for being here today. I'm very excited about trying to get something done. I probably share the sentiments of Dr. Dixon in his open remarks around his some ideas for the types of solutions that are out there that could work. We were a blank piece of paper startup back in roughly 2016. And our group came together saying we recognize that as primary care organizations, federally qualified health centers, we have far more in common than we have that is different. And when we can all get together and leverage our commonalities, we can all do better together. And that has been true since we came together. And I think the same is true for all of us and our interests in taking what is primary care and turning it not only into something that can survive, but something that can be great for caregivers, for patients, for industry, for government. And I'm really looking forward to being part of that positive change.
I'm Allison Bracken, representing the Massachusetts Association of Physician Associates, which represents PAs across the state. And I clinically am working as a PA in primary care at Brigham and Women's. I've been there for over 16 years, and I'm a senior manager there, which oversees about 45 PAs in primary care. And I really appreciate the opportunity of being here, as working on the front lines and seeing the crisis that primary care is in, and the access issues.
Thanks, everyone. My name's Steve Martin, not the other Steve Martin, so I'm sorry. But I am Stephen Martin, who's a family physician and addiction medicine specialist, and grateful to work at Dr. Dixon's with his group at Berry Family Health Center, which is part of UMass Memorial. I trained here in Boston for both residency and medical school. I've been I've practiced only in the Commonwealth since I graduated from residency 20 years ago. I've practiced 50% or more ever since I graduated. I practiced in the National Health Service Corps in the Commonwealth and am working now to help open a residential treatment site in Williamstown. And I'm here with a purview of the rural health side of things. I should mention that Barry sits on the Cobbin Reservoir, which is where all of your tap water is coming from right now. I also, to Mr. Hurst's comments, I'm on the school committee for Pioneer Valley Regional School District, and our healthcare costs went up double digits this year and is forcing very serious conversations about keeping teachers or other wonderful personnel or not. And so the costs of what we do or don't do have very quick ramifications. And I would just say to the point that independent businesses are facing difficulties, including Dr. Black's point, I'm concerned that if there must be something we need to do immediately because independent practices will be gone in a year. And I don't think we can wait for us to report out in full. So I collect stories, but 3 quick stories from a patient perspective. One, Boston Globe, front page, 2023, gentleman, suicidal and in pain, cannot find primary care for 6 months. How can that be in our Commonwealth? Our current metrics and incentives are very distorting the work such that health centers and medical centers are reaching out to people for screening, which by definition will help maybe 1 in 1,000 people over 10 years. And they're not reaching out to my patient who just overdosed in the ER last night. That is an incentive structure that we have to address. And lastly, I did a home visit recently for a family. Patient's not able to leave the house, disabled. And at the end of the visit, the father tried to give me a check and was incredulous that this could happen. This should be routine care, is the kind of care that people need in their homes that we can provide. And I really want to thank you for the efforts we're going to make together.
All right, I'm getting between everyone and the rest of the agenda. My name's Suzanne Curry. I'm from Healthcare for All, and I really appreciate everyone kind of keeping patients at the center of this conversation because I've heard that a lot, and I really appreciate you sharing stories. They're really important. For those of you who don't know us, we're a consumer health advocacy organization with 3 components. We have a direct service helpline where in the past year, we've received over 27,000 calls in 5 languages. We also do consumer engagement, including some large-scale community outreach and education campaigns, such as Where My Water Bottle's from the COVID vaccines. And we take what we learn from the helpline and from community engagement efforts, and that informs our policy work. And that's why we're here today. On the helpline, I would say for the past 5 years, we've done way more work than we ever did before, and our helpline counselors go above and beyond to not only help people apply for, enroll in, and troubleshoot health insurance issues, but people have been having trouble finding primary care providers that meet their needs and that they're able to see in a timely fashion to even get their kids vaccines for school, to address some timely issues. And so this is something that we feel very committed to and want to make sure that we keep patients at the center, we keep health equity at the center, and we're able to really make a difference here. So I appreciate everyone's comments, appreciate the important healthcare bills that passed this session. Thank you, Chair Lawn and Chair Friedman, and to our esteemed chairs of this committee. Let's get it done. Thank you.
Thank you. Thank you all for those introductions. We really did want to take this time while we're in person to be able to do that. We do expect that some of this work will be done virtually. And so just having that opportunity to be able to hear from everyone and your perspectives and thoughts. And was really struck by, everyone really talking about a sense of commitment, a sense of urgency, and a willingness to work towards positive change. So I'm really appreciative of those introductory remarks. We know that the work of this task force is ambitious as laid out in the law, as we'll walk through in a few minutes, going through many deliverables on a very short timetable. And to help facilitate that work, we have some incredible staff people who are going to be dedicated and working on this task force as well. So I want to have an opportunity for Kelsey and Millie to introduce themselves as well as the HPC and UHHS staff contacts for this task force. Lauren, if you could pass the mic to them.
Oh, yes.
Hi all, my name is Millie Bhatia. I work as Undersecretary Kiami Mahani as Health Policy Manager and will be supporting the task force.
Hello, everyone. My name is Kelsey Bertigas. I'm brand new to the Health Policy Commission. I'm going to be the project manager for the task force. I come to you from JSI, working on a lot of state projects, mainly with BSAS, but also with the Health Equity Compact, and I am very excited to be here.
Great. Thank you both. You'll be hearing from both of them as the work of the task force continues. Diving into our agenda, and I am aware that we'll be sure to end right at noon, if not a few minutes before, as this is the beginning of a busy day. But did want to, and I can't help myself, but start with a little bit of data and research to help ground our conversation, and that I think really leads into the legislative mandate that we have before us. So as you flip into your presentation, I've selected just a few slides from our recent report, which was titled "The Dire Diagnosis: A Special Report on Primary Care Workforce Access and Spending Trends," that the HPC released earlier this year. The full report is also in your binders, and I'm sure many of you have had an opportunity to look at it. We at the HPC decided to focus on primary care because, as I've said, it's a foundation of any high-performing healthcare system. When patients have access to timely primary care, they're more likely to successfully manage their conditions, to identify minor health issues before they become significant, and are less likely to use the expensive and sometimes inappropriate emergency department. Yet, despite all of this overwhelming evidence of value and efficiency, as was said earlier, we found that support for primary care is declining in Massachusetts, and the workforce is facing significant challenges of burnout and burden. This slide highlights some of the key findings from our report, specifically on the workforce front, as providers are being asked to do more with less resources, less support, and less time with patients. We know that the increased administrative tasks play a role in that. And it's no wonder when some studies show that for every hour of clinical work, there is up to 2 hours of administrative work, that many are cutting clinical hours or considering leaving the profession altogether. And we know that this will just contribute to continued access challenges. On the next few slides, I wanted to just focus a little bit on primary care spending trends and share with you some of the new data from the CHIA report that was released today. So on the first slide, on slide 8, this is our HPC analysis just showing the growth in primary care spending as compared to the growth in spending for all other services. And as you can see over the course of 5 years, the amount of the primary care spending in Massachusetts has grown very slowly, and all other services have grown much faster. And that results in a declining proportion of our healthcare dollar going to primary care. I think many people outside of this room would be shocked and surprised by how little of the healthcare dollar actually goes to primary care, 6 to 7 cents on average. On this next slide, we did the same analysis, but we actually broke it down into adults and children, and found that trend of really slow primary care spending growth was even more pronounced when we isolate for children, growing a third as fast as all other medical services. Again, just with the end result being a smaller and smaller share of our healthcare dollar going to primary care, and especially for children. And we see that play out on the next slide in terms of people's access to primary care and actually utilizing the primary care system. On this slide, we've just arrayed all of the communities in the Commonwealth by income decile, going from left to right. And the blue bar is adults, and the gold bar is children, showing the percent of these members who had no primary care visits in a year. And you can clearly see and observe a relationship between income and the fact that children in the lowest income communities of Massachusetts were much more likely to have 0 primary care visits than children in higher income communities. This is a reflection of longstanding disparities of both income, race and ethnicity, disability status, and many other factors that this task force will wrestle with. We have some new data from CHIA that I wanted to highlight as well. So on slide 11, this is a new graph and chart from the CHIA report that was just released today. And here we're showing the proportion of healthcare spending on both primary care and behavioral healthcare. Behavioral healthcare is in the dark navy, and substance use disorder services in the light blue. And then across different health plan types. So you can see the commercial market on the left-hand side, where if you just focus in on the gold part of that bar, again, a declining proportion of healthcare spending on primary care in the commercial market. But I think as an important counterpoint to that trend is the Mass Health bars in the middle, where we see that they were able, this program was able to increase the proportion of healthcare spend on primary care by 2 percentage points within 1 year. And that is a result of intentional policy choices that were made by that program. And I raise that because I do believe intentional policy choices can lead us to changes in some of these other markets as well. Another reflection of that is on this next slide, which again is both commercial, Mass Health, and Medicare Advantage, showing where is the primary care spending going. The biggest parts of these bars is primary care office visits, not surprisingly, and preventative visits. I think that what struck me with this particular slide, again, was the Mass Health portion of the slide, where again, you can see a huge shift into some of that spending going into non-claim spending, again, as a result of intentional policy choices around how we want to finance and pay for primary care, not so much perhaps on a fee-for-service basis, but on some type of perhaps sub-capitated model. The last 2 slides here just show some of that same variation in proportional spend on primary care and behavioral health, first by the commercial plans and then by managing physician group. And I think a main reflection here is that there is variation across these plans in terms of their spending percentages, ranging from 4.4% to nearly triple that and 12.6%. And then finally, on the when we attribute patients to their physician groups and to systems, we can also calculate what the proportional spend is on primary care. And here the variation is much smaller than the health plan variation, but nonetheless some variation and perhaps an opportunity to think about lessons learned from some of these organizations. All of this work in our primary care report led us to be looking to what are some other states doing in terms of thinking about increasing the investment in primary care as one lever, not the only, but as one lever to consider. And there are many states that are paving a path here, and many states that we may want to learn from and be inspired from. This slide 16, highlights, actually not comprehensively, there are actually more states, but some of the states who have set intentional targets for increasing the percentage of total healthcare spending on primary care, setting ambitious targets as high as 15% over a number of years, with many states in the kind of 10 to 12% range. That is a big increase from where we are today, but we're starting from a very small base. And so the dollar amounts to get to that may not be as large as you might think, considering how low we're starting. I also note that Virginia is another state that was not included on the slide, but is also working towards a primary care spending target. And there are many other states that are actively under consideration for this type of policy intervention. As I stated, that is one lever and tool that states are innovating with, but there needs to be, I think, a comprehensive set of policies and interventions if we're going to be successful. And so our primary care report really ended with these very broad buckets of how do we increase spending in primary care, how do we address some of those workforce challenges that we know in terms of administrative burden and burnout, How do we strengthen the primary care pipeline? How do we think about new payment models that can support all of these efforts? And I think we were so pleased to be able to issue this report because it feeds so nicely into the work of this task force. These were our very broad recommendations. I think our challenge in front of us is to take these broad buckets and areas and make them very specific and actionable. And so the law does set out for us a number of very specific tasks and deliverables on varying timelines. And I'll ask my co-chair to walk through some of these mandates.
We were remiss in telling you, feel free to get up, and if you're starting to feel hypoglycemic, there's some food there. And where's the bathroom? Is it just outside? And I forget my good hygienes. There's only one, actually there's 2 emergency exits, so Tito's. Okay. Thank you, David, for grounding us in the problem as we kick off this work today. The good news, since there was so many gloomy comments by you all today, the good news is that recent action by the state legislature and statements by Governor Healy demonstrate that this is a top priority for policymakers in the year ahead. Governor Healy, at her State of the Commonwealth, highlighted the value of primary care and the need for additional investments and reform. She said she wants to, quote, build a whole army of primary care providers out there so that when you call for an appointment, you're actually going to get one, end of quote. Historic healthcare legislation was signed by Governor Healy in January, which, among other things, established this new task force to further examine these dynamics and develop policy solutions for the short, medium, and long term. The group assembled here today, legislators, providers, experts, and stakeholders from across the healthcare system, is a clear demonstration of the Commonwealth's commitment to tackling the challenges that are facing primary care. The task force is charged with developing and issuing recommendations to stabilize and strengthen the primary care system and the increase of recruitment and retention in the primary care workforce, and to increase the financial investment in and patient access to primary care across the Commonwealth. The task force will consult with Shia. Director Peters didn't mention this, but she's my immediate predecessor as undersecretary, so she's very happy in her current position, to define the necessary data to complete this work and publish all deliverables on staggered timelines until May 2025. Or 26, since 25 is only in 10 days. That would have been aggressive.
Yeah.
Senator Friedman, you want to change the date there? So this slide, if we go to a slide that outlines the 7 legislatively mandated deliverables and the statutory deadline. So I'll turn it over to David, who'll provide an overview of the work plan and provide a timeline for completing this work.
Thank you. And I'm going to highlight at a very high level what we've been thinking in terms of how we might schedule and stagger some of this work and this meeting together. But after I kind of walk through our straw man proposal, really do want all of your input and feedback about how we are going to proceed with this work, having all committed to doing this. Now we have an ambitious agenda ahead of us. Just to walk through these specific task force recommendations really quickly. So the first is defining primary care services codes and providers. The second is developing a standardized set of data and reporting requirements for private and public payers and provider organizations. Both of those, according to the statute, are asked to have resolution by mid-September. Another important part of the task force's deliverables is around establishing a primary care spending target for private and public health plans. This may take a form similar to the ones I just reflected on in other states. The statute asks us to complete that work before the end of the year. And then there are four additional deliverables here. One is specific to payment models. The second is the fifth here, as you can see, I think of as really perhaps a little bit of a research project about assessing the impact of health plan design on primary care access and services. So thinking about, how our copays, deductibles, tiering, and other parts of health plan design may impact primary care access. The sixth charge is, to me, seems quite broad, monitoring and tracking the needs of and service delivery to residents of the Commonwealth. We'll see how we interpret that particular deliverable. And then finally, the seventh deliverable is quite significant in my mind, around really focusing on workforce and creating those short and long-term work plans to increase the supply and distribution of the workforce. So in reflecting on all of those deliverables on staggered timelines and the fact that many do intersect with each other, the co-chair and I have been thinking about what might be some of these deliverables that we want to have specific working groups be developed that could have that opportunity to perhaps dive a little bit deeper into each of these issues, and then report back to this full task force before we make any final recommendations in those areas. So our kind of initial proposal, as we were thinking about those deliverables, there appeared to be some that clearly this whole task force, I think, will want to weigh in on. And the task force will weigh in on all of these, but that felt specifically right for this full task force, which is around, as you can see here, the spending target, the payment models that go with that, and then that broad category of monitoring and tracking the needs of service delivery. As we were thinking through these deliverables, we thought that there might be an opportunity and an advantage to create a data and research working group that could be a little bit more technical and specific on some of the deliverables that are calling for defining primary care services, codes, and providers, developing that standard data reporting requirements. And then, as I mentioned, this deliverable around really assessing health plan design and impacts on access. And then as a potential other working group is really this workforce working group. There's just so much to dive into as I read this statute and I think about all of the different pieces that a working group that could really be thinking about all of the different stages that we want to try to tackle workforce and make a comprehensive set of recommendations. Felt like that might have some advantages to it. So I will be asking you all what you think of those as our initial working groups. I do want to leave ourselves flexibility to let these conversations also evolve as we continue on this work. But I also really want to urge a sense of moving quickly. I would propose that we set ourselves more ambitious goals than even what's in the statute for many of these deliverables. I do think this is a ripe opportunity to engage with the legislature in this legislative session. I worry that if our recommendations come in May of next year, that may be too late. And so we may think about, kind of parsing out recommendations as we continue our work, but also would suggest and open for feedback on perhaps even setting more ambitious goals for ourselves. So thinking about what that may look like, and again, as I've said, this is really a straw man for reaction, would be to think about a schedule that after today, that we would in short order convene and plan those working groups to begin them started on the important deliverables that they're going to then recommend to the full task force. I would then recommend that we meet again in June and have a report out from those two working groups and begin the conversation about setting a primary care spending target and the proposed payment models that would go with that. In the summer, again, I think as I contemplate this, perhaps, a meeting of the full task force, working groups meeting the month in between, meeting of the full task force, and with the working groups being able to report back up their work. But as you play this out, and we would meet again in June and July, the goal would be that by September, we would be able to set that a recommendation on the spending target, the data reporting, and the definition of codes. And then throughout the fall, be thinking about the primary, the payment models. And again, while that recommendation would be wonderful, I think, to have before the end of the calendar year. There are, of course, the other deliverables on workforce, which I think, again, if we can set a goal to get as much of this work done this calendar year as possible, I think that would be wonderful. And so, it gets a little bit more speculative, I think, as we get past the summer. So as you're thinking about this, I would mainly focus on slide 22 and 23 in terms of kind of our initial launch of this work that brings us through to July. As you can see then on our proposed timeline, that again, the goal would be to try to do as much of this work this calendar year as we can accomplish. So that is the conclusion of our proactive agenda and presentation to you. We want to use the remainder of our time, our next about a half an hour, to open this up to discussion. I have some discussion questions here, some of which are quite broad in terms of just reflecting on what does success look like for you. What of all of these topics that have been tasked of us by the legislature, are there pieces that are missing? Because I do think this commission, while I really want to keep us focused on our deliverables, has a broader mandate as well. So helping us think through, are there other topics that we want to make sure that we're creating that space for? As we're thinking about this initial kind of first couple month push, are there areas where you would recommend that we think about different or additional working groups? And then finally, in some of these questions, want to begin a conversation about what all you have at your fingertips in terms of data and resources that might be able to contribute to the work of the task force and the staff that's going to be leading this work. So some broad questions. I'm willing to kind of take it wherever you want to go in terms of broad priorities for the work or thinking about the work plan. I saw Dr. Altman's hand up first, and then I'll go this way.
So as I look, David, at number 7 on the deliverables for May 15th, 2026, create a short-term and long-term workforce development plan. To me, in academic medicine, we've got goals and objectives, and goals are like the big picture, what we want to accomplish, and objectives are how do we get it done. And I think the working groups are the objectives. How do we get it done? In kind of a simpler way to put it, the workforce development plan is we have to fix the job and fix the pay. If we fix the job and fix the pay, the workforce will take care of itself. We've been spending too much time over the last few decades talking about how to fix the workforce in a symptomatic way. A good doctor sees their patient and tries to address the root cause of what is causing their ailment and addresses the root cause and not treat it symptomatically. We've been doing the opposite from a health policy point of view. So what I would propose is that instead of a working group on workforce, we have working groups on all the different things that we need to do that would generate the workforce. So you had proposed a working group on data and research with 3 bullets on that working group. I would propose that each one of those bullets is a working group. Defining primary care, which is the first working group, is a behemoth in and of itself and deserving of its own work group. I don't think I see a bullet for defining spending targets, even though it's one of our deliverables. That also, I think, should be its own working group. There are different spending targets that have been established by different states and countries and organizations, and one working group could pour into that and make really evidence-based, thoughtful, factual recommendations about how we should establish that. So I think we should think of the objectives of the workforce and establish 4 or 5 or 6 working groups within those objectives to really get some good information to inform that.
Thank you. I appreciate that. And I do agree with your sentiment around attacking the root causes. That was one of the things we really tried to dig into in our report. And, you know, open up for reflection, you know, how many working groups can we all want to commit our time to? There is so much to dive into in each of these. I do not disagree with that at all. And open to kind of thinking about what the right structure and balance here is. Mike, and then.
Thanks, Director. My observations are that I think you landed a solid work plan. Ultimately, you have to line draw and point to certain actions, and I think you did a really credible job in putting together the work groups. A couple of observations or comments. One is, I hope that we can work from a common data set as opposed to building out a fact base again. I do think that there's an important set of information that's already out there that is validated and respected. And while we need to ground ourselves in it, I think we would not be fruitful in the use of our time by developing an alternative fact set. Number 2, I do think that there's important communication buy-in through the work groups. So one group obviously impacts the work of the other, and we'll just have to mind that. You know, the staff and the support will have to make sure that things don't bleed back into another set of conversations, because the issues are so, as Dr. Altman mentioned, so inextricably bound together that I think we would do well not to kick the can to the next set of conversations outstanding. And then lastly, I do think there's a set of questions relative to, and this can be drawn out. It doesn't have to be a separate work group. It can be through the defined work groups that you have out there. But essentially, I'll call it making sure the money gets to the practice, gets to the primary care doctor and not stuck somewhere misaligned. And I think that's incredibly important to call out, because if we're going to do this in an efficient and high quality based way, we have to make sure that the money flows back down to the doctor who's actually providing the care and is not stuck in an administrative layer or at a system level. So those are my observations.
I think I saw a lot of faces there. So we'll go with Barbara, then Matthew, then Stephen, and I'm sure Eric didn't raise his hand, but he looks like he wants to say something after that. So we'll go to Eric and then Mark.
Thank you. My first question has to do with governance of this group. I'm not sure, how are decisions made? Do we have votes? If we vote, does it have to be unanimous, or do we unanimous? And when we go to work groups, how is that brought back? And also, you know, the idea that we'll figure out a spending target by meeting, 3 months in a row. It's like, how does that work? And so, and do we bring in outside people to help? So if you could speak a little bit about that, that would be great. And then I have a follow-up question.
Turn your first question over to Mark. I mean, to David.
Mark, if you want to weigh in too, that's fine. Listen, I do think that we have an opportunity to shape a little bit of how we want to do this work. I do think that this, as I read the intent of this law, that this is a task force where I think we should be striving towards consensus, but that may not always be possible. I do think that any recommendation that comes out of this task force should have an opportunity for every single member to be able to weigh in on whether they support or do not that recommendation. So I do think, as I've been thinking about the working groups, it's really not that they are making any decisions per se, but really about an opportunity to have a deeper level of conversation and then bring that conversation back to this full task force for final consideration, and that this full task force would deliberate and be able to review any final deliverables and make all of your positions known about what the final recommendations are.
Thank you for that. So in terms of, I wanted to second Mike's comment about really focusing on how the money flows. And also in terms of defining, I mean, there's been so much work on defining, and Chia went through that, like 5 years ago. And the Millbank Fund brings states together to define primary care. So there's a ton of work that's already been done. So I would just say, let's not reinvent that.
Thank you. We're going to Matthew, then Steve.
Thank you. I wanted to come back to that same issue in the first question of the discussion that you suggested, the top priority and what would it be a success. The crisis is stemming from a crisis of patients not having access, of taxpayers paying an unreasonable amount for healthcare, of employees and employers paying an unreasonable amount for healthcare and not getting the outcomes from it. So the implicit in raising the percent we're spending on primary care is what most of us know, that is your biggest return on investment to actually save the healthcare system money and deliver better costs. And that return on investment has to flow not just to the providers providing that care to incentivize them to fix the workforce and to make it better, but back to the patients, to the employees, the employers, the taxpayers. And making sure that that happens, I think, is where a lot of this work often falls down. So that is number one. It's increasing the investment in primary care and making sure the flow of the money is correct. And then the second one is the burden and complexity, because with a lot of this, and we talk about data sets and we talk about how we're going to report on it and how we're going to gather all that information, that burden flows to the people at the front lines providing the care. And that's part of what many people are referring to as fixing the job. So we need to fix the pay and fix it in a way that's transparent and correct. And we need to fix the work in a way that doesn't burden the frontline clinicians with collecting the data.
Thank you, Matthew. Steve?
Thank you very much. And yes, my sense is that by May of 2026, we will not have unending resources for primary care. And so we are still going to have to make decisions about the cardinal task force recommendation defining primary care services. I'm an amateur historian of medicine. I'm also a professor at UMass Chan. I studied this with colleagues internationally. Primary care has been loaded with doing everything, soup to nuts. Fix people's social determinants, or at least ask about them, but not have resources to do anything about them. Move their blood pressure up or down, move their A1C blood sugar up or down, help someone who's grieving a lost parent, help someone who's cut their arm, help someone who's got all the above, help someone who overdosed last night. And unless we are very clear about the best return on primary care investment, we will end up in the same position next year because we will not define what primary care really is important for doing. And the literature here is very clear. Primary care is not very good at primary prevention. What's good at primary prevention is public health. And the House of Medicine, my House of Medicine, has stolen a lot of resources away from public health and put them in a very expensive prevention model. And when you're doing prevention, you end up with the situation you have where there are no urgent care visits on a certain day, but there are a lot of people having physicals. So why is it that someone who can't breathe on the phone can't get a visit when someone who's no symptoms is privileged for that visit? And it is because the certain way we have created incentives and metrics incents me to see someone for asymptomatic prevention and fill care gaps that they don't even want filled, and not address what they actually want help with. And there's only so much time to work with. But I'll just finish this by saying there have been international studies. If you want primary care to make everyone's blood pressure at a goal level, you will have to hire 5 times your current healthcare workforce. We're not built to do that. That is public health's job. They're great at it. We haven't given them enough. And I think part of our definition has to be, how do we define public primary care, but also how do we define public health? Because we've put way too much of their work in our work, and we're way too expensive to do it.
Thank you, Steve. As expected, lots of challenging thoughts. So we go to Eric, Mark, then Christina, then Barbara, then Christina.
Thank you. I'm somewhat struck by the jump to countermeasures and solutions without even defining what our goal is, right? I mean, I think what we all want is for people to have health first and foremost. And if we could do that without primary care, let's do that. I don't think you can, but, and then have access, everyone have access to primary care regardless of the color of the skin, the gender identity, or sexual orientation. And if we could do that by spending less on primary care, that's a victory. But, you know, jumping to, we have to spend more on primary care without even defining what we're going to get for that larger spend isn't particularly helpful. What if we could make our primary care docs so much more efficient that they could take care of a much larger panel of patients by using physician associates and nurse practitioners as part of a bigger team, by leveraging AI, and we didn't need as many primary care? That would be a success. But we're jumping right to, we got to spend more on primary care, we got to change the comp plans. Michael and I are meeting at 2, we'll talk about that, to make sure the money flows to the doc. I think the provider, frankly, the people around the provider are doing most of the work that Steve was talking about, and that's where the money needs to flow. And saying it has to go to the provider, it's going to take away from a much lower cost workforce. So I think we should just start with the end in sight. We want better access to primary care. We want better health for the populations in Massachusetts, and we want to do it at a lower cost. And now let's talk about what countermeasures we should put in place. Instead of jumping to, people came in this room with their countermeasures that they wanted to pass, instead of just really opening the mind and saying, how can we achieve those goals? How can we reduce the cost, improve the access, and improve the health of our patients? So that's where I would start with all of this.
Thank you, Eric. Mark, then Barbara.
Yeah, thank you. I resonate very much with a lot of what Eric just said, and also what Mike said earlier about having an accounting mechanism to make sure that what appears to be primary care spending on paper and in health plan side accounting actually flows to the primary care system writ large for all the primary care services that Steve was alluding to. Not necessarily the primary care providers, although some of that, of course, should probably end up there. But absent that accountability mechanism, this could end up looking like something good on paper that actually doesn't improve anything in the primary care experienced by patients. With that in mind, I think I would be very happy if this group comes up with some clear, enduring goals for how we define a good primary care system that could be used by talented civil servants. And I think our civil servants here in Massachusetts are amazing. And the resources and flexibility for the civil servants to go ahead and do the hard work that I think is actually impossible for this group to do over the short pace of time here, to get into the technical details of things like how we define primary care and how we're going to specify complicated payment models. The reason I say that is I have evaluated many payment models and also been on the design side of many payment models. And I know those in the room who have done this kind of work know that you never get them right out of the gate. They're never great. They're rarely good. And most of the time they're harmful when they first get started. And you have to have the ability to adjust those live. And that can't be done through the legislature. As good as the legislature is, that has to be done by the talented civil servants to have the flexibility to go ahead and do that. And that's where having these clear goals can be really helpful. Otherwise, I fear that this is going to be another one of these things that I evaluated many times at RAND, where a very smart, well-intentioned task force at a state level got together and had another failed medical home type experiment. And sometimes that enhances and worsens primary care burnout rather than the reverse. I've seen it happen too many times. With that in mind, I think we should make sure we're learning from folks who have done primary care spending targets in the past. And I would strongly suggest adding an agenda item here to learn from those states that have done this, especially California, which I think has maybe struck the right balance finally between setting targets and letting a team of talented civil servants do the grunt work of modifying the program as it goes forward.
Mark, can you tell us what a civil servant is?
Civil servants?
Talented civil servants. Sorry, I wasn't enunciating. Talented civil servants. My bad.
Thank you.
Sorry.
Oh, folks working in EOHHS, folks in HPC, CHIA, wherever you want to set up a new system. California has actually set up a new department to do the operations and technical work to implement their primary care spending target. I think that's a model worth considering.
Barbara, then Christina, then Laura, then Renee.
So I'll try to be brief. I think that one of the things we have to remember is that when we talk about primary care services, we have to really define what we're trying to do, because when I define a primary care service for a primary care capitation model, it's going to be very different than when I define primary care services looking for what our target is. And we have to be very mindful of the fact that claims really is not all that there is to monitor. Primary care, if it's going to be properly defined, includes is a team sport. If it's not what I do in the examining room and what I put a claim into Blue Cross, it is what happens outside of that with care managers and social workers and a pharmacist and a secretary who makes appointments and someone who calls the special office and says this patient needs to be seen today or tomorrow, not in 3 months. It is a team, but those are not billable services. So we really have to pay attention to what we're talking about. And one of the things I always think about, the kind of care I want to deliver and what we should aim for, is a system where every person, I don't care whether they're immigrants or live in the state, every person who is here in this state should have access to a primary care provider. And the medicine that we should support is concierge type medicine without extra pay, because that's what our patients really deserve. And that's what we should be aiming for. And much of that is not driven by what is done in claims. And I think we just have to keep that in the back of our mind. Thank you.
Thank you for that, Barbara. Christina?
Yeah, 3 thoughts. One, I'm not sure if it's irony or a paradox, but certainly, you know, the healthcare system is full of both a paradox of excess and deprivation. So if you look at your slide number 10, and you thought about that slide, but modifying that slide so it was showing you the % of primary care spend in relationship to the economics of the community, right? You'd see that the amount being spent on primary care was inversely related to the economics of the community. I don't have that data, but I'm pretty sure it's what the data would say. So I think it's important for us to keep that in view as we go about the 7 components of the work. Health centers are an example of that. Health centers have been studied to show that on total cost of care in a risk-adjusted method, they are roughly 23% more effective on total cost of care and equal, if not better, on quality. And what happens is that they are not the beneficiaries of those economics. So they generate 23% more value. That value is essentially extracted from those communities where the health centers reside, where the patients reside, through the health insurance carriers, and is moved to high-income communities to pay higher rates to AMCs and other aspects of primary care, which are more well reimbursed. So I think that is really important to fit into the 7 domains that we're looking at. Adding on to the top of license, like, yes, it's true. And we say it all the time. I would add also that we did a little study interviewing caregivers after clinic and saying, of the patients that you saw, what %, and it didn't require MD level of care. It was, what % do you think didn't require licensed clinician level of care? And the findings were 50%. Had thing 3, what was that? Thing 3 is important. Question. We are going to have failures in primary care, right? And it will be the organizations, I believe it was Dr. Black pointed this out earlier in her introductions, that will fail this week, next week, during this 2-year period, during a 1-year period. Does this task force want information on these failures? Does this task force want any role in understanding, observing, studying, maybe having those failures not be failures?
Failure means closing?
Yes.
Senator Friedman wants to exercise a right to jump line.
We do want to know about that. And this task force is not at the exclusion, or is not, everything else is not at the exclusion of this task force. We have many, many things that we have to do at the same time. I actually wrote down Lauren Black, NP, North Blackstone, can't keep the doors open. We were going to beeline over to her afterwards and say, "What? Tell us, okay?" Because we're going to try and take every single opportunity we can. I think Chair Lawn feels the same way. We're going to do everything we can to push to do immediate, short, medium, and long term, because we know we can't solve all this in one fell swoop, in one commission. So we will be noting that, at least, yes, we will be noting that.
So Christina, yes to failure. Laura next, then Renee.
Mark made the comments that I wanted to make. I'm hoping, I was kind of breathless as we were going through this. There is a lot here to get done in a very short period of time. And I think we can look to other states and other models to help inform our work. And I know the HPC is well equipped to do that, to guide this discussion. So I would hope that we're not going to reinvent the wheel, but look at some best practices and things that are working in other states and from other literature that you can look at. I do think, and I think Matt believes, that paying primary care physicians more is important, but doing that within our existing spending targets and within the cost benchmark. We want to attract people to this practice, and I can't help but believe, based on what I've read, that folks aren't choosing primary care because they can make more money in specialty care. And so I think that we want to commit to that, and that's certainly what other states have committed to. And that's not to say that nurse practitioners and other support isn't important within the practice, but we do believe that primary care needs to be invested in, but again, within existing spending targets. And that might mean that specialists get paid a little bit less to invest in primary care. And I think those are my major, I think one last point is I'd like to understand some models in our state that are working. Mass Health has their model. I know we think it's complicated, but we'll get working through it. And Atrius and Reliant, I think we always think are high performing practices. So I think we should understand a little bit more about them.
Thank you. We're going to Renee. Is your sign up, meaning you want to speak? Okay, so Renee, then Laura, then John, and I think we'll be getting close to time. I know that our elected officials have to be rushing back to the top. So I think those might be our last ones. So Renee, Laura, and John.
Okay, so first to address what Christina was actually talking about is actually labeled as the inverse care law. The availability of good medical care tends to vary inversely with the need for the population that's served. And it was Dr. Tudor Hart in the UK, and he actually gave this tie to my mentor, and I'm wearing that today. It's a good tie. It was here to remind me that it's really about the systems. And one of the things I'm going to sort of gently push back on Dr. Dixon is we're not asking for, pay is not the issue. It is patient access. And in order to have better patient access, we have to be able to pay our organizations to do team-based care. Full stop. Whatever way you can make that happen, great. And I'll tell you, one of the challenges is, as a CMO of a community health center, one of the challenges is I have like 25% of my expenses are to pay for people who are dealing with billing. The bureaucracy of billing is taking money out of primary care. I would rather be paying for MAs, community health workers, BH, anyone doing clinical. I love my finance people. They are lovely. But the fact is, to do patient care, I need those dollars going towards clinical personnel. So if we're going to do anything, we have to deal with the juggernaut of the billing bureaucracy. And finally, when you're talking about we need the money to flow to primary care practices, this is how we do it. Comprehensive care, you should be able to roll out of residency and hang up your slate. If we have the ability to simplify billing so that you can do independent practice, I guarantee you the big health systems will send their money to their primary care practices. Because you know what? If they don't, they'll lose their primary care providers. So if we make a model where you can do independent practice like that, where the bureaucracy of billing is gone, and you and your friends can get together and say, let's put on a show. If you can do that, I guarantee you the big health systems will be doing a much better job of taking care of their primary care clinicians. We need competition, and that is independent practice without the burden of bureaucracy of billing.
Thanks, Renee. Laura?
It's also important for us to consider things that are out of our control. I forgot to mention in the introduction that I actually was a senior executive at Commonwealth Care Alliance for a long time, as well as vice president for population health at Point 32 Health. So I have a unique perspective of being on the ground now, directly providing primary care, and having sat in that chair and said, oh, you know what? The PBM is going to give us this type of what's it called? A rebate. And now I am the provider sitting in the chair going on Cover My Meds and trying to figure out what medication my patient will be able to get. So I think it's just important that we look at how we can influence not only minimizing disruption for our patients when it comes to health systems deciding to drop particular health plans, or health plans turning around and deciding to drop particular products, leaving providers to scramble and try to find either new health plans for our own patients or patients who are struggling to find providers that will actually take their insurance. That's one thing to consider, as well as making sure that we are providing stability for our patients, that we can say, okay, I know that for the next 2 years, yes, you can have this particular type of inhaler, and I don't have to worry about whether or not I'm going to get a new PA to get it, or you'll have to switch because it's no longer covered.
Thank you. John, you get the last words before David will take us home to end today's meeting.
Thank you, Mr. Chairman. I just had a basic question really for the co-chairs, if I could. If this was brought up, I apologize. Are we starting from an assumption that the size of the pie, premiums, co-pays, taxpayers is big enough, perhaps too big? And is really the issue is how it's divided up? Or is there an assumption that maybe the pie needs to grow? It seems like that needs to be a basic first step that we all should agree upon.
I'm sure the proper answer is it depends, but because I think it depends how much are you spending on your social needs, how much right? One of the differences between us in Europe, and they say, oh, we only spend 6% of our money on total care, but then you look, oh, university is free and retirement is free, right? So I think that we are assuming that as taxpayers and as a society in general, we can't afford to increase the percentage of money that's going into healthcare. I mean, that's just like there'll be nothing left. Like we have other needs. So yes, we are starting out with that principle that we can't afford for us to grow to go from 23 to 27 to 44. Like it's just we just can't do it. So David.
Well, thank you for this discussion. I think you've given both of us a lot to think about as we launch this work. And I really appreciate the guidance and advice about how we might segment out this work while still having broader goals that we can point to as our North Star. So I think one of the things we'll do some reflection after this meeting and think about everything you shared with us and get back to you just in terms of, very specific next steps. I do want to share, I think a little bit of my perspective on this, which is I think we get the system we pay for, and this system does not value primary care, and it shows up in the money, and less of the dollar is going to primary care. To me, that's a market failure, because we know that when spent right, it can provide tremendous value. And so when I look at what states do in terms of setting spending targets, it's about correcting something that the market is not doing on its own. Whereas we as a society have said, we value this and we think this is worth investing in and supporting. And I think one of the questions that this task force will wrestle with as we think about that potential policy lever is, where do we want that investment to specifically go? How can we track to make sure that it's supporting both, primary care provider, the primary care team, the practice of primary care? And so, part of the question with some of these spending targets is, well, what do you want to actually incentivize that money to be spent on if we are increasing that portion of the pie? How do we track that and monitor that to make sure that we're not acting in cross purposes with our overall goals? I do think there's a lot to learn from other states who have been wrestling with these same topics, and I appreciated the comment earlier. I do think it may be valuable for us to hear directly from California or some others who are further along about their experience in doing this and some of the questions they've wrestled with. And certainly we can help synthesize some of that information and provide it out to this task force as well. So the final thing before we adjourn, we do want this to be a task force where we're learning. And so one of the things that we've done is we've created and established a dedicated web page for the work of this task force. All of our materials and discussions will be part of that. We're also curating a kind of a resource library with that website as well. So if there are particular resources or studies or things that you think are really important, both for other task force members, but for the public to have available, you guys have incredible both Rolodexes and such a deep understanding. Please just email our general inbox, and we're going to try to cultivate that public resource as well. So listen, much work to be done. I felt like this, while I feel daunted at the end of this conversation, I'm still emboldened by the fact that there is such a widespread commitment to making this work. So I will thank you again for your time and commitment, and know that we will be in touch and be asking more of it in the weeks and months ahead. We will be sending out next steps.
Shall we recycle name tags?
You can leave them here, and our staff will collect them for future meetings. And yes, we'll be in touch shortly on the specific next steps. I think we do want to try to hold some calendar dates for the main task force so that you can all be sure to plan in advance. But as we think about maybe bringing some smaller groups together in the interim, we'll be in touch.
Are those firm dates? So when we reschedule that, they're not going to be moved around. So we should reschedule based on those dates.
These dates I would lock in. Yes.
Okay, thank you.
Thank you, everybody.
Yeah.